Good afternoon, everyone, and welcome to the next webinar in our COVID Conversation series, Team Approach to Assisting Patients with Advanced Care Planning. My name is Keita Scholl. I'm the Office Manager for the Coalition for Compassionate Care of California. Now I'd like to introduce our CEO, Judy Thomas. Welcome, Judy.
Great. Thank you, Keita. Thank you to everybody who's here today joining us. We really appreciate it. Next slide. For those who aren't familiar with the Coalition, we've been around since '98, and our mission is to improve care for people who are seriously ill by making conversations about serious illness a normal part of everyday life and palliative care a normal part of our healthcare system. Next slide. So we want to let you know, first I want to thank our sustaining supporters that you can see them here on this slide that make the Coalition's work possible. Next slide. And we've started a campaign we're calling COVID Conversations to promote good quality conversations here in light of COVID. So you can visit, it's a multi-pronged initiative that includes a website or newsletter, these webinars, working at a policy level, getting out consistent messaging, and working with our local partners and clinicians on the ground. So if you haven't checked out our website, do that. We are collecting a lot of these great tools that are being created both here in California and by national organizations and putting them on a single page on our website so you have one-stop shopping to find these great tools. And with that, I'll pass it back to you, Keita.
Thank you, Judy. It's now my privilege to introduce our presenter today. Seiko Izumi is an associate professor at the Oregon Health and Science University School of Nursing. Her current research focuses on the development of the healthcare system to support and move advanced care planning upstream and to provide patient-centered care and expand palliative care to people living with serious illness. Dr. Izumi received her PhD in nursing from Oregon Health and Science University School of Nursing. She is a Cambia Health Foundation Sojourns Palliative Leadership Scholar and Fellow in Palliative Care Nursing. Welcome, Dr. Izumi. I'll turn things over to you.
Thank you, Keita, and good afternoon, everyone. Thank you very much for having me here in this webinar. And I think this is just transition. And now I hope I have the control. Okay, it's working now. So again, thank you very much for being here. The COVID pandemic itself is affecting every one of us, professionally and also personally. How it's affecting us is very different depending on where you are geographically or where you work in the healthcare settings and what your roles are. But I believe that we all have something to contribute and we can help the patient. So I'm going to talk about how each member in the healthcare system team can contribute and how we can work together. Sorry. So today I am going to be focusing on how to assist patients to have advanced care planning in the context of COVID pandemics. Because I believe that advanced care planning may not solve all the problem about COVID-19, but I believe that it could alleviate many of those issues. Clinicians always strive to ensure patients receive the care they want to have that is aligned with their goals and values. This is true with or without COVID. However, when the healthcare resources and capacity is limited, like in New York and New Orleans now, avoiding non-beneficial and also the unwanted care becomes especially critical. Avoiding unwanted and unbeneficial care by having advanced care planning can minimize the risks of the virus transmission or the exposure to the virus, moral distress among the healthcare providers, and also the reduced grief among the healthcare providers, patients, family members, friends, and families. Advanced care planning itself is a process. So this is a model we use to describe the continuum and steps of advanced care planning. So the vertical, the level goes from the healthy to end of life. So that is a reflection of the patient's health. While a person is healthy, they should have self-decision makers and completing advanced directives in case they have the accident, car accident, or the acute illness. This is recommended for all adults. When the person becomes sicker, when the person becomes ill, then they should have the goal of care conversation with healthcare providers. When the person gets sicker, then consider to have the POLST. And all of those steps are the planning, preparing the patients and their family to make end-of-life decision. That is the epic of this triangle. So this model was developed in the pre-COVID time, but I believe that this model is still useful to guiding us to understanding what advanced care planning is appropriate for each patient in front of you. But with the acute onset of the novel coronavirus and without curative treatment, the progression of this process become much more compressed. So the person who has been healthy become progress into the ill, and the time for end of life become very, very short and could be rapid changes. And because everyone can get sick very quickly, in this the COVID environment, goal of care conversation may need to take place earlier. So I want to go through the process of advanced care planning very quickly, because most of the elements and steps are already discussed quite extensively in the prior webinars. So if you did not have a chance to look at the webinar the last 2 weeks, I would recommend it to view it to get more thorough information how to do what to do in each steps. But if you have any question regarding the specific steps, please let me know so we can discuss about that at the end of the Q&A. Other things I'd like to tell you first is that what I'm trying to do today is to providing the useful language and tools for each steps. And sources of those tools and languages are included in the last slide, so you do not need to worry about it. But I tell you upfront that the many materials I talk about here today is developed by the various very credible resources, credible sources. So just be aware that a lot of great materials are available out there. So first step is the naming surrogate decision maker. So this person, the surrogate decision maker, may be called different names: healthcare representatives, healthcare proxy, durable power of attorney for healthcare. But this person, whatever the name is, every adult should have this person in their mind. And here is some useful language that with COVID-19, you may become very sick quickly and not be able to speak. So I would recommend that you name a medical decision maker who you trust to make decision if you can't. So anybody in the healthcare system can say this to the patient. And the useful tools for patient is available through the Prepare for Your Care website. So this is the material prepared by the Prepare for Your Care website. And this is for the material for the patient. So when you have this conversation, you can give the material from prepare for your care to the patient. So it's very, very clearly described that, what the role of this person is, and, who would be the good person to take this role, and what to do and how to use this the named person. So next step is the completing advanced directives. And again, similar to the surrogate decision maker, completing advanced directives is recommended to all adults. And the most important thing is that the patients talked with their family member and the healthcare surrogate decision maker about what is most important to them. If the family member or the surrogate decision maker knows what the patients want, the patients are very likely to receive the care they want to receive. But having their wishes and what kind of care they want to receive expressed in the document is also helpful. So here is some useful language. And so some patients may have the advanced directives already. Some people already documenting it many years ago. So it is important to ask them, do you have completed advanced directive before? And if they say yes, then you can continue to making sure that if they are still thinking same way when you completed the document, given the COVID-19 environment, they may change their mind what kind of care they want to receive. Do you remember where they have the form? Does anybody else around them, the patient, knows where it is? And remind them again that it is important to share the information in this form with your family member and friends. And also remind them that bring the copy of advanced directive if you go to the hospital. If the person say no, I do not have advanced directives, that is fine, but help them to start thinking about this. And again, prepare for your care would be the great resource for the patient to start this advanced process. So next step is the goal of care conversation. Asking the patient to talk about their goals and values is often very difficult. So the way use this serious illness conversation guide developed by the Ariane Lab in Boston. And this the serious illness conversation guide. What I'm showing on the screen is the modified version for COVID-19 context. But this original guide itself was developed to have the goal of care conversation with seriously ill patients. But I found that the flow and language presented in this guide is also useful to have any advanced care planning conversation, particularly to explore what is important to the patient, what is important and the goals and values of patient. So I am going to go through this the conversation guide a little bit more detail. But the flow of this conversation guide is like shown in the slide. So setting up, assessing their understanding about their health, sharing your understanding of the patient's condition, explore, that is the most important, what is most important things for the patient, what is their worries, what is the important ability they want to keep, what is their preference of the medical treatment, and does loved one knows what is important to you. Then closing and make a recommendation. So the next few slides are the piece and the flow and the language used to set up and assess and the share, explore, and the close and recommendation. And I go through this very quickly, but again, the slide will be available after the session, and you can also find the conversation guide in the Ariane Labs the website. But again, I just want to re-emphasize that because COVID, the virus, the progression of the symptoms when you are infected by the COVID-19 is pretty rapid. So sometimes this is the usual flow, and serious illness conversation happen usually when the patients become very sick. But these days, anybody can get the COVID-19, and everybody can get very sick very quickly. So having this goal of care conversation earlier stage, even with the healthy person, may be the one thing you may need to consider when you are talking with the patient. So the next step is offering POLST. The POLST is the portable medical order for the life-sustaining treatment. Usually, when the person becomes very sicker, usually the 1 to 2 years of prognosis, the offering the patients to have the POLST is appropriate. With COVID-19, offering the POLST to person with a high risk for for COVID-19 is appropriate. Particularly the patients who are likely to developing the serious complication and death, potentially death from COVID-19, like person with the underlying conditions, older adults with frailty. Those are the appropriate to have POLST documented, so the person has a medical order what kind of treatment, life-sustaining treatment they want to receive. I just want to go very quickly the differences between advanced directives and POLST, because there seems to be a lot of confusion between the differences between those two. So advanced directives is that the appropriate for anybody who are older than 18, and this is the patient expression of the patient, what patient's preference for the treatment in case they cannot speak for themselves. On the other hand, POLST is that appropriate for the people with a serious illness. In case of the COVID-19, the patient who are high risk for the COVID-19 infection is appropriate. And the POLST providing the medical order, so that the medical order can be carried out by the emergency medical personnel. On the other hand, advanced directives is not guiding the emergency medical personnel. And as the medical order, POLST required to have the healthcare provider's signature. On the other hand, advanced directives is patient's wishes, and it requires the eyewitness or the notary, but it does not need to have the healthcare provider's signature. Again, if you have any questions about the POLST and advanced directives, please let me know. So the last step of the triangle model is the end-of-life decision making. So all of those steps I talked about so far is to prepare for the end-of-life decision making when time comes. So end-of-life decision making itself of the small epic of the triangle itself is not part of the advanced care planning. This is the actual time. The prior steps are the planning steps. However, when some patients get this point very quickly and unexpectedly with COVID-19, so here are some the language to have this conversation as a part of the advanced care planning in COVID environment. So this language is coming from the serious illness conversation guide, and here as a part of the closing phase, and you make a recommendation, and you would say that So I heard you say that, blah, blah, blah is important for you. And given that what you told me, here is my recommendation, A or B. Here's another language. This is coming from the VitalTalk communication playbook. And this is particularly useful, those languages are particularly useful when things are not going well. And when you need to discuss about the cold care or the code status in the most likely in the hospital settings. So that is the kind of steps or the recommended process of the advanced care planning in the usual time and some adaptation for the COVID time. But here I like to share some proactive advanced care planning practice in time of COVID. So if in this time, even healthy person could face the serious illness with COVID virus. And many people really worry they may be infected and become very seriously ill. So reaching out to all of your patients and doing following things like sharing the facts about COVID-19 and counseling how to protecting themselves. And also engaging the patient and their family to have a plan, namely the surrogate decision maker, naming, share what matter and what is important to them, and completing or the reviewing the advanced directives. Doing these things and reaching out to the patient may seem to be a lot, especially when your team members are reassigned to other places or the funeral, but thinking about who in your team may be positioned very well to do this. In primary care clinics I work with, the medical assistant is making a call to the patient to canceling the appointment because we are closing down to the non-essential or the non-urgent care. While they're making the call to the patient to canceling the appointment, they are doing this. They are, start to asking the patient how they are doing and just give them some information about the COVID-19 and encouraging them to think about the naming surrogate decision maker, what is important for them, and completing the advanced care directives. So if you see patients with much more high-risk patients, maybe physicians, nurse practitioners, physician's assistant may be able to do those things when you have a telehealth visit or something like that. Very similar things, reaching out as many as possible, sharing the facts about COVID-19 and the high risk because those are high-risk patients, to counsel them how to protect them, how to protect themselves, but also letting them know that they are high risk, so they really need to think about those planning. So again, naming surrogate decision maker, sharing what is important to them, and for this population, offering the POLST may be appropriate. So healthcare professionals, I'm sorry. So the title of today's webinar is about the team approach. And I really believe that everyone can pitch in, everyone can participate and help each other. So I believe that everyone in your team member can help patients to have advanced care planning. So just think about who is well positioned to do this in the given situation and building the systems to support them to be able to do this consistently and effectively. Another important thing is that whoever has that conversation with the patient, documenting it, where everybody else can see it. So what the patients share with you, that what is important to them, who is the surrogate decision maker for them, everybody else can learn about that by seeing your documentation. Earlier conversation would help for the later decision making. So if you are working in the primary care settings and having the conversation with the healthy patient, but the patient maybe get infected, and maybe the calling to the primary care setting again to asking for the triage, should I go to the hospital or not? Then earlier conversation would help them to make a decision much easier, and it's not going to be a surprise. They can make this advanced care planning when they still have some peace in mind. The healthcare professional that your patient may see when they become sick is likely not to be you. They do not know the patient. Those healthcare professionals who are going to see the patient when they are admitted in the hospital do not know the patient. So I would recommend to make a plan and create the process how to share advanced care planning conversation and the information to the healthcare professionals who are outside of your clinical setting. How to communicating, how to delivering those advanced care planning information to the outside of the external healthcare professional. Because we are all in this together. Team member here can count another healthcare professional who are working in the hospital, another the COVID, the specialized the unit, or anybody can be the part of the team. Now I want to switch the gear just a little bit and just addressing the unique issues related to COVID environment. So social distancing and isolation. So when you are having the advanced care planning conversation with the patient and sharing the facts about COVID-19, you may also want to explain that it is possible that visitors will not be allowed in the hospitals. Many patients, family members, and also some clinicians do not know about this fact. And no visitors could be the very important factor deciding for the patient whether the patient should wants to go to the hospitalized or not. So addressing this issue of the visitor may not be allowed in the hospital, it seems to be very important. In long-term care facility settings, also visitors may not be allowed. So if your patient choose to stay at home, even with some the serious illness or with COVID symptoms, or if the patient decide to go back home, I want you to plan and implement specific action to follow. For example, setting up the follow-up telephone visit or the home visit. Making sure that the comfort measure is available at home. Does the patient have the medication to ease the symptoms, or do they have enough medication to managing their underlying condition? If the patient has a shortness of breath, is making arrangement for the home oxygen. Also, most of the patients want to go back home, need the caregiver where they live. And instructing and supporting caregivers become a huge deal. Making sure that they have enough food at home. Can they cook? Is there anybody who can help the patient to take a bath and bring them to the bathroom? And also how to protecting each other. Patient from getting the virus from the caregiver, and the caregiver from the patient. And consider to arranging the hospice services if appropriate. How to do this would be very greatly depending on where you work. But I would encourage you to collecting the information and resources and create a plan how to support patient in those situations. In the social distance world, obtaining signature on advanced directives and POLST may be difficult. And the regulations related to advanced directives and POLST is varied by state and the institution as well. But I have here a lot of the innovative workarounds and exemptions given that this is a pandemic. And most of healthcare organizations are willing to respecting the patient's expressed wishes, even though it may not be complete and it may not be missing some notary or the signature. During this time, the telehealth become predominantly the modality to communicating with the patients. So here are some tips for the telehealth. The idea is the figuring the technology first, and then let technology disappear. And here is some the rather detailed, concrete information. And so, if you are not familiar with the telehealth, just following those tips and practice make it perfect. Having the advanced care planning conversation through telehealth is a tall task. And the photograph, the picture on this slide is the Ariane Lab, which developed the serious illness conversation guide, also created this sample telehealth serious illness conversation. So that is a great resource for you to see, how it can be done through the telehealth. The trick here is that at the beginning, when you start the conversation, just acknowledging the strangeness of this moment. And also then the transition into the advanced care planning conversation. And at the end, you summarize what you heard, what the plan is, and reaffirming your commitment to the patient. Those ease the patient's mind greatly. And there are additional more the practical logistic tips for the telehealth. So documenting and billing as you usually do in the face-to-face appointment. So document patient's consent for telehealth service. Verbal consent is fine, and just document as it is as usual. And telehealth can be used for advanced care planning these days. So just using the billing code to bill for the telehealth advanced care planning done by the telehealth. Some additional information about how to use the telehealth and how to use the billing code for the telehealth. Those informations are shown here. And here's as I promised, here's the useful tools and the guidelines and materials I collected over when I was preparing for this presentation. So I think that is it. And thank you very much for all of you are doing it. And as I said earlier, we all can pitch in and we can all help each other. And having advanced care planning conversation really reduce greatly the moral distress and grieving of the many of us. So thank you.
Thank you, Seiko. Very helpful. If people have questions, go ahead and enter them, and we'll be taking those. We do have a couple of questions. So our first one is that in the situation that many healthcare professionals prefer to have, one surrogate to work with, but in many cultures, decisions are made by consensus of the family or a larger group. Do you have any suggestions on healthcare providers address that reality for many of the patients that prefer that it's not just a single person serving as a surrogate.
Yes. So when this conversation, if the person wants to have this backup person, secondary person for the surrogate decision maker, that is perfectly fine. And in some culture, they prefer to the more group decision making. That is perfectly fine. But when you are communicating with the patient to select one or two person, just tell them that we want to have the one person we can contact to. Then that surrogate decision maker person can call for the family meetings or whatever they want to do. But as a contact person, we want to have the one person who we can primarily contact to. That will help the patient to kind of sorting out, and meantime allowing them to make a group or the family decision making. Another thing, important things for the multiple family members is that telling the patient to let the other family members know that who you choose for the decision maker. So some people may sometimes sibling rivalry happens. So if I name my surrogate decision maker, if I name the second daughter for my surrogate decision maker, then my first daughter may be upset. Why do you choose blah 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 over me? So to avoid that kind of confusion, when you are selecting the one person, let the other people know, let other family member know that who you choose for the decision maker. So those are my advices.
Great, thank you. So another question we have is, for individuals who have completed an advanced directive or POLST that make it clear they want comfort-focused care only, do we send these people to the hospital? They really want to stay at home with loved ones. So what do we do if they need medical treatment?
That is a great question. So if it is stated as do not resuscitate and do not want to go to hospital on POLST, then the emergency the ambulance people need to honor it. So if it is clearly stated on the POLST, then they should not take the person to the hospital. And but important key here is that when the person having some symptoms and call to the ambulance, but let them know that I have POLST and POLST medical order says this. So the emergency people can follow that order. Advanced directive is a little bit more tricky. It is not medical order. So if someone called to the 911 and the people come to pick them up, they automatically send them to the hospital. But when you are admitted to the hospital or when you are at the triage center, tell whoever the triage place that that I have advanced directives or that my mom has advanced directives, and it says that she does not want to go to hospitals. She wants to stay home and get the comfort care. Then the triage person should triage a person to go back to the home. And that is the time it become a little bit more tricky because providing the home care in this environment is very, very challenging in terms of finding the resources, finding the home visiting nurses to help them to take care of them at home. So if your patients raise this question, then you need to think about how to support the patient who decide to stay home, to stay where they want to stay.
Great point. We have a question that says maybe this is more of a comment. So I'm going to share this and then let me know if you have some comments on it. So this person says, I've done some education about the use of ventilators, and some of her patients, after hearing on the news, you know, in light of COVID, there's a lot of information about how ventilators are life-saving, and that some of her patients want to reconsider previous decisions about foregoing ventilation, even and elect. Now they're interested in electing ventilation, even if it's not clearly in their best interest.
Yeah, that is very difficult situation. Great comment. So let me clarify. So the patient prior to this, the patient was thinking about the no CPR, no ventilator, but hearing on the news that how effective it is, they change mind and they want to be on the ventilator. That is that the question?
Yes, correct. Yeah.
Well, that is very interesting. I think it's depending on the patient's conditions and also the critical state of the healthcare. If the healthcare system is available, if the ventilator is available, and then if the patients want to have the ventilator, it is, you know, we should provide the care what the patients want to have. However, some patients have you know, the misunderstanding the effectiveness of ventilator or CPR or those things. And so it is very important when you are sharing the fact about the COVID-19 as well in relation to the patient's health conditions. If the patient have an underlying condition and seriously ill already, and the likelihood of ventilator would be helpful is pretty low. So sharing that information and with the patient and really have a candid discussion with the patient, what would be the really helpful for the person at that moment. And can I go back to some slide because there is some good example language to share with this. Yes, this one. So maybe not this one. So if you go to the, okay, this sentence would be helpful to the number A would be helpful to have the conversation. But in the Ariane Labs, the serious illness conversation guide, it has a great the phrases to explain it. Sometimes for the patients like you with a serious illness, sometimes the ventilator may not be helpful, and therefore my recommendation is this. So that there's some language, so that you may be able to use that language to have a candid conversation with the patient. But bottom line, unless we need to do the rationing, so we should respect the patient, the care treatment the patients want to receive. But given that the patient have the good understanding what would be the helpful treatment or non-beneficial treatment.
Great. And just a reminder to everybody who's on the webinar today, you will receive a copy of the slides and a link to the recording. So another question we have is, since the advancement of the disease may be quicker in the time of COVID, what are your thoughts about filling out a POLST ahead of time?
That is a great question. I have an interesting conversation with a geriatrician, and who has seen a lot of older adults, could be very healthy, but the older adult. And the person, even though the person is like 83 or something, but very quite healthy. And this geriatrician thought that that she would not need the post completing the post in the usual time. But the patient actually bring this up, and this patient was worried that that she may get very sick very quickly. So she wanted to have something in hand, meaning that she wanted to have the post completed. So the geriatrician talked with them, completing the post for the case of the COVID context. And the geriatrician asked the patient, that after the COVID, if you want to discard the post, that is perfectly fine, and we should have another conversation to decide if this is what you want or not. Then patient was firmly said that no, this is what I want, and even after the COVID. So it could be the case that the even healthy person may have the post, may not be harmful. But if that is the case, then having the conversation after when COVID is over, and making sure that if this is what they want, even after the COVID environment.
Great. We have another question that you talked about the team approach. Can you talk a little bit more about who should be part of the team? Are there people who we wouldn't normally think about being part of the advanced care planning conversation team?
Great question. Thank you. So I think about the team in the very broad term, and I also understand that the team membership varied very much by each settings. So I'm primarily working with the primary care settings, and even among the primary care clinics, the membership of the team varied dramatically. And so the mostly providers, so physicians, nurse practitioner, physician's assistant, whoever work there, nurses, care managers, social workers, often medical assistant, the pharmacist, I'm sorry, pharmacist, everybody in the team, I would count on them. And in this COVID context, whoever who can touch the patient have an opportunity to talk about this. So just whoever asked the question, think about who would be the team member, who are in your group, and who may have the time and opportunity to talk with the patient regarding this. So example, I shared with you one of the primary care clinics I work with, because in this group, the medical assistant was in the COVID environment. The medical assistant was the one who is making a phone call to the patient to let them know that your wellness visit is canceled. For it's scheduled for the next week, but it's going to be canceled because of the COVID. And ask the train this medical assistant to talk about COVID, and give them some, asking them basically like how you are doing, and we are all thinking about you, and providing some information, and also recommending that everybody can get affected by this virus, and thinking about deciding the decision makers. Even considering to completing the advanced directives, we would recommending it. And if you need some materials, we can send you those materials and so forth. So in that particular clinics, they find out that this medical assistant is very well positioned to have this conversation. So I would encourage you to consider who are in your team and who has the opportunity to talk to the patient.
Great, thank you. Another question is, does a telehealth advanced directive, when completed through a telehealth appointment, need to be redone after the crisis is over?
The advanced care planning should be a process, and it should be done the multiple times. And non-COVID time, I usually recommend that when your health condition change dramatically, or when your value change dramatically, and that will be the good time to revisit advanced care planning. Otherwise, I also recommend to revisit advanced directives periodically, like every 5 years, or if they're getting older, every 1 year at the time of the wellness visit. So similarly here, that even after the COVID is gone, then hopefully, then having another conversation. Okay, we talked about this before during the COVID the outbreaks. And do you have any change in your mind, or does this still staying what you want to have? So having that conversation periodically would be very helpful.
Thank you. We have a question here for somebody who stays at home, does get seriously ill, stays at home, and passes away at home. Do you have thoughts about showing the POLST form for the person who comes and to pronounce death after the person has arrived?
I'm sorry, would you say it again?
So what are your thoughts about the validity of showing the POLST form to whoever arrives at the home to pronounce the death after the person has died?
That is an interesting question. I'll be honest with you, I've never thought about that. But if there is any concerns related to the cause of death of the person, that may be the time that somebody may want to take a look. But if the person is already deceased, and then I am not sure that what is the use of the POLST for that situation.
Yeah, I agree with you. I think it's more a sense of maybe it's evidence that this was an anticipated death. I would think that a lot of people who are, certainly, especially during COVID, that are at home and seriously ill, we hope that they can get onto hospice and palliative care and be overseen by a medical team. And so the person pronouncing the death would be part of their care team. But because this does move so quickly, that might not be the case.
Right.
Just a comment here that this person says that she also includes the faith community, parish, and parish nurses as part of the advanced care planning conversation team. They have access to their own congregation in their homes and know their medical history.
Yes, definitely. So this is all hands on the deck approach. And I noticed that there is some the variation of the urgency of COVID, the pandemics. So some place like the hotspot, like New York, they are urgently needing the all ICU, and everybody, the healthcare providers are needed in the acute care settings. But luckily, some place like Oregon, where I live, and look like the California also look like a very things are under control to some extent. So there is no urgency in terms of it is not a crisis at this moment in terms of the acute care settings. But I think I really believe that even without before the COVID time, I think everybody can pitch in. So even the parish nurse may not be the part of the regular team in my team, but if that is a person who can touch the patient, use them, work with them, and work together.
Great. We had a comment from one of our attendees in response to the issue about showing the POLST after a person has died. And she says, as a hospice nurse, if the POLST is not shown, the medics have no way of knowing the patient did not want CPR and there was in order to withhold it. So certainly for our medics that arrive if 911 is called, that is absolutely critical to show it to them.
Great
Yeah.
point.
We have another question. If a patient is appropriate for POLST, how do you suggest starting the conversation? I'm afraid people will get scared if I suggest a POLST in this COVID environment.
That is a great point. So that is the serious illness conversation guide I shared pretty much. That has a very good flow and language to start the conversation. And that particular guide is designed to eliciting the values, patient's values and the goals. But the beginning part of stating that the the person who has the underlying condition may be very high risk for become very seriously ill from the COVID virus. So that there is something I would like to talk with you to have the plan to what we would like to know what kind of treatment you want to receive when you become sicker. So it has a very nice language to start the conversation. And this kind of conversation is always frighten the patient, and patients become very emotional. But so just give them some time to understand. But most of the patients understand, yes, I am the high risk, and having the plan is important. Having the plan would help my family to make a decision if something happened to me. So that is the gentle way to start the conversation.
Thank you. We have another question here. I have a client with an advance directive that says no heroics, but has allowed antibiotics. Is this consistent, or is this an issue?
I think that is that how the person who completed the advanced directives see. So for this person, maybe the antibiotics may not be the heroic. So the one thing that you may want to consider is that when you are seeing the advanced directives, and just clarify, ask the person, what do you mean by the heroic? And then the person may be able to describe, like, I do not want to have the chest compression, or I do not want to have those drama I see in the TV shows, or so just clarify what exactly heroic means to the person. But if you are seeing the advanced directives when the person cannot explain what it means, then just follow the whatever the person expressed in the advanced directives. The heroic effort and the use of the antibiotics is not necessarily conflicting.
Thank you. And I know one of the points you touched on was obtaining signatures in the context of social distancing. So I just want to remind people the coalition does have some information about how to do that on our website. And we are also in collaboration with a number of other organizations going to be asking Governor Newsom to issue an executive order providing some clarity with completion of advanced directives and POLST in this time of social distancing. So keep eye out for our newsletter. We will keep you posted on that. We have another question here. Oh, it's right at 1 o'clock, so maybe we can just slip in one more question before we wrap up. And that this individual has a patient with intellectual disabilities that has a conservator. So there's already an advanced directive and a POLST. Are there other considerations in this environment with a person who has a conservator?
No, I think it's just following the usual procedure, whatever the state or the institution has. And that is great. This person has a conservator, and POLST and advanced directives clearly stated. So we as a healthcare provider know what exactly to do. So that is very, very helpful.
Great, thank you very much. I think that's our questions today. Keita, I'll pass it back to you.
Thank you, Judy. And thank you, everyone, for being with us today. Thank you, Dr. Izumi, for sharing your information. We hope you all have a great afternoon.
Thank you.